and welcome to the Disruptive Dental Science Podcast. I'm Dr. Matthew Miller. I'm a clinical ambassador with the Dental Advisor, and I'm going to be joining Matt Cowen, the Director of Research at Dental Advisor today, to translate the science behind an exciting product that has been around for a while, but it's just now getting even more attention. So today we're going to talk about silver diamine fluoride. You might have seen this more in journals lately and people getting more awareness about this product that's been, like I said, around internationally for a long time, but really not until probably the last decade has been more prevalent in the United States. Back in 2014, the FDA gave approval for the use of SDF for desensitization on root surfaces and tooth surfaces. In 2016, the FDA approved it for arresting caries. Since then, it's primarily been used in a pediatric population, but as we see its efficacy and usefulness, we can see how it can be really more beneficial in adult populations and aging populations as well. So most popular SDF formulas consist of 38% SDF solution. It's a 25% silver, 5% fluoride, 8% ammonia. And what that ammonia does is it stabilizes the pH so that the silver and the fluoride are more effective long-term. And the rest of it is basically deionized water. The fluoride content in SDF is much lower than the fluoride content you would find in a typical fluoride varnish. But the studies actually show that the fluoride in the SDF is more effective and has greater uptake within the tooth. So it's a beneficial product that can be pretty versatile in your practice. The way it works is the silver actually reacts with proteins in the mouth and in the teeth, and that then disrupts the bacteria and creates an antibacterial effect over a long period of time. It then occludes the tooth surface and the tubules within the tooth, therefore creating that desensitization effect. And moreover, as it penetrates the tooth, if there's caries present or caries affected tooth structure, it can penetrate that pretty deeply and remineralize it. So studies actually show a 55 to 70% caries arrest rate with only one application, and a 90% caries arrest rate with two applications. So I'm excited for our podcast today. Matt and I are going to take a deep dive into the science and to the clinical applications of SDF. Recently, we tested a new product by Centrix called SilverSense. It's a 38% SDF solution, and it has a little bit of a blue tint, so it's a little bit more visible when you're applying it. We've done a lot of research on it and some other SDFs that we're going to talk about as well, and can't wait. And thanks for joining us.
Hello, and welcome to Disruptive Dental Science. I'm Matt Cowen, Director of Research at Dental Advisor. I'm joined here with Dr. Matthew Miller. How's it going?
Hey, Matt, it's good to be here. Great to see you.
Yeah, so in this podcast episode, we're going to be talking about silver diamine fluoride.
I love this. I do a lot of dentistry with this, not just pediatrics, but I do a lot of adults and even older patients as well. It has a lot of different applications especially for remineralization. If you're doing selective caries removal in the event that you want to avoid maybe a root canal, or maybe you have an issue with non-compliance, or maybe there's an issue with severe decay that you identify in a hygiene visit and you can't get them in very quickly within the next couple of weeks. So it's a great tool to just go ahead and put it on the lesion to arrest it and then treat the tooth. But you can also use it during treatment. I do that a lot restoratively. So I've been using it pretty consistently since about 2016. And as you mentioned, there's a few different ones on the market. Some I feel like they all perform, they all do what they're supposed to do, but some I like the handling, better than others. But I had a question for you. You mentioned with the different formulas, some companies I know report that they're less, it's less abrasive to the tissue, the soft tissue, than others. And I was wondering if that's to do with the ammonia levels. And then secondly, like with the amount of silver in them, some have 38%. Are they all consistently like that? Or are there some that have less of a percent of silver in it and more fluoride, or vice versa? Or how does that work?
Yeah, so I think most of the formulas are very similar in terms of how much silver content of like 25% silver, and they range plus or minus a few percent here and there. I'm not sure that anyone has been able to determine that having a 1% more fluoride or less is, able to find an effect in that. I think the main difference is the one from SDI that uses potassium iodide to remove some of the silver that has tarnished in order to precipitate it out to kind of lower the staining. Some studies are mixed that it might be slightly less efficacious after the potassium iodide application, but it's really mixed. And clinical research is one of the hardest, to actually get clean data in. So, you can find some studies that show it's less effective and some that are it's as effective. So, overall, they're both shown that they're more effective than sodium fluoride or other
Mm.
fluoride just based varnishes alone.
Clinically, I've used, Advantage Arrest. I've used Rivistar Aqua, and Centrix Silver Sense. They all have, they all work pretty effectively. The neat thing about the two steps, while you're doing two steps, is like you said, the potassium iodide that bonds, to that silver, and I guess the silver, is it silver nitrate that it's bonding to?
I think it's just atomic silver,
Just atomic
that
silver.
it's ionized silver that,
Gotcha.
yeah, has been released.
Yeah, and you can see the precipitate, come out. Their first generation still turned colors with curing lights, but the second generation not so much.
Mhm.
The silver sense I like a lot. I've been actually using that a lot more recently here in my practice, just because it's easy to use. It's has a bluish color. You can see where it is. Some of the clear ones you couldn't see it, and it gets on your countertop. And now you've got with ambient light, you get a brown countertop. Definitely done that a few times. And so you can visualize it better. And I like how you just wipe it off. You can just wipe it up. And if you, in the sense that I use it in as well for restoratively, if I'm doing any kind of light curable bioactive materials on top of it for more of a therapeutic restoration, yes, the curing light will cause discoloration, but you can get around that by beveling the cava surface margin. Just the other day this week, I think it was Tuesday this week, had a very deep lesion. Um, Patient has already had a couple of root canals. She's got limited funds. She needs a lot of other work. So we're trying to, she had a deep lesion, got the majority of the decay out, where we're still kind of like now in the affected dentin at this point. And so we applied the silver sense on it. Then I put on a calcium silicate indirect pulp cap, and then light cured that. And then, of course, we had a little bit of discoloration after the curing, but the silver sense itself didn't really discolor the tooth at all by itself. It wasn't until I added the curing light element to that. But then it's easy to just, I was still prepping around the cava surface margin, beveled it, and then used a composite resin restoration, and you couldn't even tell that there was any discoloration. But I advise the patients of it that there may be over time some changes in color change, but generally speaking, I do this in posterior teeth. But as you mentioned, a lot of people can use this for crack identification, for root desensitization, really anywhere in the mouth. And in all honesty, as long as there's no decay there or really a significant crack, it typically doesn't change the color of the tooth unless ambient light is getting into it. So if it's a posterior tooth, you're not really going to see it.
Yeah, so let's talk about, what is the main, probably only downside for SDF is kind of the chance that it can discolor tissues and teeth. So it really will only discolor enamel if it's carious enamel, which means it has pores from demineralization. So the silver gets trapped in the pores and can kind of change color over time. The color change is from the actual silver that is kind of unreacted and tarnishes from light exposure. So, that's why the curing lights is turning it dark, is it's kind of accelerating the process of the tarnishing of the silver. And in the same way that, the silver, if it gets into dentin tubules and then it gets exposed to light, that can also change color. And especially, if it's healthy dentin, there's, very, very little kind of color change. It's kind of, it's like kind of a grayish shade. But if it's carious dentin, then it turns darker because it has more
Mm.
penetration. So, that's also a useful way to kind of tell, if you're, looking at caries affected dentin, you can really identify easily where it is. Then you can say, oh, well, that's a really dark spot. Try it. Is it, much softer than then, maybe you want to excavate a little more. But, it is really useful for, I think, kind of identification in some ways, because if it gets into it can easily identify cracks, because if it gets into a crack in the same way, if like the pores of a tubule, then and then you hit it with a light, then you can easily visualize the crack. And uh, at the one end you might go, well, the crack is discolored and it doesn't look great, but on the other hand, it's protecting the tooth, because it's going to help fill in the crack a little bit. So there's going to be a little less bacterial infiltration. Bacteria that does get in there is going to, survive less. So, might be, on the one, it's going to help, keep the tooth alive in most cases. But yeah, so we tested in our lab, using it in restorations. What are the different materials and restoratives that can be used? There's a lot of research that glass ionomers are really good pairing with SDF, because the glass ionomer can work with the SDF to help prevent secondary caries, but also RMGIs, resin composites, new bioactive materials, all can benefit from SDF being used under it. But the real question is, what is the best material combination that you can use to kind of limit the staining or discoloration over time? So we did some testing in our lab that looked at that. And we found that really one shade composites kind of predictably isn't really a good thing to block the light of SDF or any kind of staining for that matter, because it tends to pick up the
Mhm.
color around it. But you can put an opaque layer if you're at the bottom of a prep, and the dentin might stain over time. If you put an opaque layer of it, that can block most of any of the color change from being apparent outside. Glass ionomers tend to be more opaque than composites anyway, so they're also very good at kind of blocking any shade shift over time. And you mentioned some techniques that can help. So you can, instead of, blasting it with air, which might splatter the liquid all over, you can just kind of use a cotton pellet to remove excess, liquid
Yeah.
from the prep. Prepping the margin can really prevent any of staining from being apparent on the margin. So there's a lot of ways to kind of mitigate, the
Yeah.
discoloration under restorations.
Those are all great points. And as you're speaking, I'm like, just in full agreement, and there's so many different uses for it. But restoratively, as we're talking about that, like self-curing materials, dual curing materials are really helpful and advantageous when using SDF. I
Mhm.
find that when I'm using it, I'm typically wanting to get remineralization and some sort of bioactivity. And in that case, I'm most likely going to use a bioactive, either GI or RMGI, mostly usually an RMGI, um, and either going to let it self cure in that situation, or if we're going to do a sandwich technique, then I can always bevel that margin if it is discolored. But you mentioned cracks, and I've actually had some experience because I do a lot of endodontic therapy as well. So sometimes if I'm looking
Mhm.
for a hairline crack that may or may be a culprit, or just something that could be troublesome for the tooth, or at least gives me an idea of the prognosis. If we're in the pulpal chamber, and so I've used it there as well, to identify cracks, and then I can take a picture of it with my intraoral camera, and advise the patient, the prognosis, or maybe we have a different modality of treatment that we then go forward with depending on the nature of the crack. So, in those situations, I'm doing a root canal. We're going to be putting an indirect restoration. We can block out any sort of discoloration, but I would myself and my patients much rather would know if there's some sort of fracture in the tooth. And yes, it's going to identify a crack, but we're also hoping to get a little bit of remineralization and stabilization, like you said.
Yeah, from the studies of the SDF, it does greatly increase the remineralization, making, kind of the soft surfaces that have been demineralized much harder, which, really using at the bottom of a prep, that can actually increase the bond strength and bond because the underlying, structure that you're bonding to can be stronger as well. Um, yeah, and I think one of the best uses really is kind of as an interim treatment. I imagine there's a lot of cases where you get a new patient and, well, you see they have, several areas of caries and, you might not be able to treat all of it at the same time. And it might be weeks before you can schedule them. I think just applying it as an interim treatment until you can really see them and do a final restoration is, probably the best thing you can do to, prevent further, uh, carries before you can see them again, right?
Absolutely, I agree with that, and it's quite a incredible clinical phenomena because you can have a soft lesion that you apply this SDF to, and then you can tactile feel it with your Explorer, and it really feels hard and glossy smooth. It's pretty remarkable that it can do that, and even if you know you need to excavate more, because typically I try to get the gross decay out and then apply it,
Mhm,
because of it can only penetrate so much, and I think we'll probably talk about that in a second, but it really is a nice interim therapy, and then depending on the depth of the lesion, I may use it again at the time of final restoration. But certainly, I've used it in adults with deep lesions. I've used it on children that maybe we have a compliance issue, or we don't want to traumatize them with a lot of restorative work, or maybe sedate them. So we'll apply that until they're more capable to handle therapy. So I have cases that are over 6 years old where we've had arrested caries, we've had zero progression of decay, the teeth remain vital, and that's, to me, clinically, I've had a great success with it. So that I had started using it shortly after I got FDA approval, and using it in conjunction with like a fluoride varnish in a lot of cases too.
mhm. Yeah, yeah, I've seen that as a tip that, putting a fluoride varnish kind of over the top can help
Mhm.
increase, how well it, can absorb into the tooth structure because the SDF as it's applied is kind of a liquid. So, it
Mhm.
might, if you just apply kind of a layer over top, it can help, the uptake of fluoride and silver into the surfaces. But, since we're talking about, kind of depth of penetration, the studies generally are a little mixed because teeth are so variable and caries especially are so variable and how the demineralization actually affects the tooth. So from what I've seen, the actual depth in an active carious lesion can go as far as about 2 millimeters in a really deep lesion.
Mhm.
But general penetration is only about 30 microns in like sound enamel and about 200 to 2 to 300 microns in sound dentin. But because you have a more porous and demineralized like carious surface, it can penetrate much deeper. But it's quite variable, and you can't just trust if you see a deep lesion that you can just throw it on top and
Yeah.
it's going to fix the whole thing.
Yeah, true. I mean, it has to be able to get there, but at least we could stabilize it and kind of stop the outer progression. Um,
Yeah, because it
uh,
can, it can kind of fill in the outer layers,
yeah.
so, less penetration is going to continue to reach it. Yeah.
Is there any risk for clinicians in a situation where they're close to the pulp and maybe we're within that window of penetration? Can this be an irritant to the pulpal tissue at all? Do we have to worry about that?
Yeah, I think indirect exposures are generally safe, if you're definitely not putting it straight in the pulp chamber, there's absolutely no risk for that.
Yeah.
Overall, we're talking about micrograms of
Mhm.
the material being placed, and there's very very little risk for adverse, actual biological effects. And it, like I said, it's been used for over 100 years at this point in one form or another. Um,
How do we, I guess, how do we get the word out? I mean, we're doing this podcast, but I talk to clinicians all the time, and we always want to be conservative because there's this whole initiative in dentistry for a while about just ultra conservative dentistry, and I feel like this has to be in the toolkit. I
mhm.
was talking to an endodontist. And of course, I work with a lot of other GPs and specialists. And, for so long, we thought that this was just for pediatrics, right? So how do we get the word out and kind of incorporate this into our normal workflow? I mean, I've done that in my practice, but it's, I think, getting over the fear of discoloration, right? And you can't just use it recklessly. You've got to understand how and where to use it, so that you can handle any sort of potential discoloration. But are you aware of, like, is this gaining traction in the research world? Is it getting traction in universities and things like that?
Oh, absolutely. I mean, it's been talked more and more. I remember an IADR in 2015 that there's, a keynote address about it, and, just kind of going through all of the research that at that point was kind of all international.
Mhm.
And, it was kind of an eye opener for a lot of people that, this was a new, tool that they could use. And, for conservative dentistry, when you want to preserve as much tooth structure as possible, I mean, this is probably one of the best, products that you can use to, try to save as much tooth structure as possible. Overall, yeah, I think this is something that is being used more and more often. And as far as how we can, get the word out, this podcast is probably a good step.
Yeah. But yeah, I see it more and more in different journals, and when I
Mhm.
started doing it in 2016, uh, it kind of felt like thinking out of the box, really. And I had
Mhm.
to, tell the patients, like, okay, well, we're going to try this technique, and I'm going to do multiple applications over time with fluoride, and then started using it. Well, if we can do it with this, what about if we use it underneath restorations? And so I started just kind of naturally using it like that. And then it was really validating to have, have it appear in journals and other research. And anything that I do, I always want to make sure it's scientifically backed before I try it on a patient. And that's
Mhm.
what I love about our work with the dental advisor. You guys do a phenomenal job in the lab to really validate things and claims beyond what just a manufacturer may or may not report. So, when you guys tested this, you did I did a lot of clinical work with it, but tell me, you did a lot of actual in-depth research with this in various modalities. What were some of your findings?
Yeah, so in this latest round, we looked mostly at kind of the color and aesthetics aspects. So we made different preparations into teeth at different depths, and we used I think 18 different combination of materials to see what was the effect of using opaque layer versus non opaque layer. Layering composites, different composites with different opacities, that we used, different glass ionomers and RMGIs. It's very very interesting to see. And then we also, because this is kind of an important step, we also stored the teeth for over 4 weeks because just kind of ambient light can also slowly change the color if you're using just a self curing only composite. So if you don't use light curing immediately, you're not going to see any color change. But if you use, just a totally self-curing composite or glass ionomer system, then it will change color to whatever, to somewhat close to what it would be if you used the light over time, over the course of weeks or months. So we had to store it for a long time to see what the overall color change is going to be. And I think the main result from that is the light curing ones didn't really change that much after 4 weeks. In some of the cases that using the self-curing composites and materials had a similar change overall to the light curing, but depending on the opacity of the different materials. So it was a really kind of interesting experience to, look at these in the lab and track them. We took pictures and measured with spectrophotometer to, get an independent view of if, what was the color change over time.
It's
Yeah.
pretty impressive and sounds very exacting, especially measuring the amount of color change like that. So if we're using it in the posterior quadrant and on, posterior molar, can we expect it to always change color, even if it's not in ambient light? I mean, it's just going to naturally do that on its own. So we should be prepared to, use some opaque materials.
Yeah, I think you should always, if you are concerned about the aesthetics, in the posterior region, using an opaquing layer over the dentin base. That can always help a little bit for any color change. I would expect less color change in the posterior region just because there's, presumably less light exposure to that. But um, yeah, overall, if you just put an opaque layer over the dentin and it's far enough from the enamel walls, that's not going to show through. We found that you can see almost no color change.
I have a random, like, hypothetical question. What if because I wear very high power light with my loops, or let's
Mhm.
say we're doing an adjacent filling like a year later, right? And we applied
Right.
SDF to that tooth, but we use maybe a self curing resin or material. And let's say we're doing the tooth in front of it and we use a curing light on it, but maybe it's a year later. Will it still all of a sudden discolor that tooth with the SDF all that time later, or no?
Yeah, so I'm not entirely sure really because I don't think the longest wait period between using the light activation is more than a few weeks from
Okay.
what I've read, and I haven't tried that myself. Um, the ones that I did in the lab when it's just exposed to ambient light over a long period of time, it changed color. So
Sure.
it's quite possible. I didn't really see any color change
Yeah.
for like just several days to a week with ambient light, but slowly it darkened.
I didn't know if it went dormant or if it always stayed
Yeah,
in kind of that, if it just stabilized over time or if it stays in that kind of um, uh,
yeah, yeah. I think
state.
it seems to be if it's just has the unreacted kind of silver that is trapped there, it can react to the light and oxidize. Yeah, oh, interesting
Be
question.
interesting. Yeah.
Yeah.
I'm just thinking, like, if you're doing it, I could see, someone worried about that. They apply it and then they're doing a hygiene check, let's say, and they've got their loops on. They're not using the UV filter or anything, and then all of a sudden these teeth just start turning dark. Uh, I haven't had that happen to me, and I've used it on a lot of patients. I haven't had that issue, but just thought I'd put it out there to see.
Yeah. So have you, had any follow-ups, patients that, you've used the self-cure, self-curing no light when you're replacing it and we're able to see it over time and, to see clinically, if
Yeah,
there's any color change.
a little bit. Yeah, over time, I'm using if I'm using a self cure like RMGI,
Mm.
um, over that maybe a little bit, but in those situations, it's been kind of negligible and not really not really a deal breaker for the patient, and sometimes the tooth already has stain and you have to think if it had decay there, it's kind
Mhm.
of a bit compromised anyway. Where where I've noticed the changes are the ones where I used multiple types of materials, where I did like a capping layer with a stronger resin. That's kind
Right.
of where I've seen it because of the light curing. But the other ones that where I have cured, I've been able to pretty well block it out with a lot of the opacers on the market. Um, do a pretty good job to really kind of
Yeah.
mask that dentin layer out. And then you could always go back and prep or use like a micro abrader. I use that a lot. In an area where I've actually um, used it, and I've talked to Dr. Bunik about this as well. Incipient lesions interproximally. It's a
Mhm.
good, it's a good interim therapy to arrest the decay and kind of monitor to see if it does progress, or it's certainly a lot more conservative on those incipient interproximal lesions than doing a full-on class 2. So that's another area for a lot of use for clinicians, where easy to apply, and it's not like so caustic that you have to rubber dam everything, and
Right.
it's for me, I'd much rather do that. And if there's a little staining in approximately, especially in the posterior, that's not an issue.
Yeah, from my understanding, it can, stain like soft tissue like gingiva,
Mhm.
but that stain will fade over time as the, kind of
Yeah.
regrows. Oh, or
Yeah.
the cells regenerate. Yeah.
Exactly. As they start the cells turn over, it's really kind of it's minimal at best. It's minimal at
Yeah.
best. It looks like a little pigmentation, but it goes away as the cells turn over for sure.
Yeah, I mean, I think the bottom line is, having a little bit of dark staining because a lesion has been arrested is, a
Mhm.
lot better than a dark stain because, a large carry
Mhm.
has developed.
When using it for root desensitization, if it's in the anterior, you mentioned about if it's if there's caries there, or if there's a crack with bacteria in it, then certainly that can darken, which could be a cosmetic problem for some people. Um, and then how do we manage that? That becomes the next issue, right? So if we're looking for that crack, or if that person is symptomatic, maybe that can help us identify it. But if we're not looking for it and is no symptoms there, what's the likelihood of it, colorizing that fracture line or craze line, perhaps?
Yeah, I mean, it's, such a case by case basis for,
Hmm.
any of this because, you know, um, whether it's a deep enough crack to even, have, penetration from the SDF or, how it darkens, kind of depends on, what their environment's going to be.
Hmm.
How you restore it can kind of change it. Think I want to reiterate that, you can have very aesthetic, restorations when using it as a base
Hmm.
liner,
Yeah,
under restorations.
yeah, we can reiterate that for sure. If it's a very large lesion, get some gross decay out and then apply it, and then be conscientious of using opacers or using self curing or dual curing materials, but you can still get a good aesthetic outcome.
Mhm.
And as we're talking about that crack in the interior, I was thinking, well, if SDF can get in there and discolor it, so can coffee, wine, tea, probably a lot of other things. So we're probably going to be able to identify that crack even earlier, with the staining. So just the SDF will make it a little more stained. But maybe
Yeah,
you could put
I
a veneer or a crown or a composite over on top.
yeah, I mean, I think it's better to, see cracks when, SDFs have been applied because it's actually, a useful staining that's going
Yeah.
to, both lower sensitivity, probably it's going to, prevent bacteria from growing inside the crack and getting worse. Structurally, you may need to, depending on how deep the crack is, restore it in some way. But in some cases, you're probably going to be fine just observing it over time, right?
Yeah. Yeah, that's a good point, and I think you had a good catchphrase there, useful staining, and if it does stain at all, I mean, because quite frankly, we're seeing these new generations where they're not discoloring the tooth unless it's
Right.
really the ambient light that's doing it, right? Like you were saying. So the SDF itself doesn't discolor it. So if we can avoid situations with ambient light, putting a filter on our headlamp, things like that. But if in the event it does stain, we know that there's pathology or problems
Mhm.
that exist there.
Yeah,
So that is, like you said, a useful identification tool.
exactly. Yeah, and, just kinda reiterate, you can have very aesthetic, restorations when using the SDF as, a base under a restoration. It's in a lot of cases, you can't tell, that it's under it after the restoration's completed if you kind of take a few precautions in some cases. So it's, I think, historically this has been since it's, come to America, been used in kind of the pediatric and geriatric populations. But, what's really missing is, being used for the rest of the adult population. And, I think that's kind of where a lot of the messaging kind of needs to change around the use of the product because, it's a very useful tool for dentists to use.
You're exactly right. And I think when it originally came out, when you look at how it was used, by the World Health Organization as like, well, sort of like just to arrest decay, but we really don't have either the facility access or technology or materials to then properly restore them. So it was sort of like a band-aid. At least that was how it was kind of portrayed in some of the journals initially early on several years ago. But now it's to me, it's crucial, and I feel like everyone should be using it in using it in some way to help, um, remineralize tooth structure, prevent sensitivity. We want to be ultra conservative in our approach, right?
Mhm.
So yeah, I think now it has so many good applications, and it's become, I don't know, more widely known. There's more awareness beyond just pediatrics and geriatrics. But you think about patients undergoing cancer therapy or xerostomia, or maybe there's something else going on, right? And even if it's not that, it's just you want to just kind of quickly arrest the decay and get and do what's best for the patient.
Right. Yeah, I mean, I think we listed like 5 good uses for it, and, you know, it's up to the dentist and, clinicians to, decide, when is it a good time to use for that patient, you have to talk to the patient and, make sure they're okay with the potential of some staining or discoloration over time. But otherwise, it, is often going to be one of the best options available to actually keeping teeth vital, which is, really the most important aspect for long-term dental health.
You're right. And, I even hate to even bring this up, but it's the world we live in sometimes is, with insurance, right? And we're seeing a lot of insurances have a specific code for this. They're aware of it. They understand the value of it, the benefit
Mhm.
to it. So, for clinicians out there wondering, well, how would I bill for this? Can I charge for it? What can I charge? Like insurances do cover this. It's a very viable option to treat decay.
Yeah, I think, at least since 2016 anyway.
Yeah.
Yeah, and I mean, this is a relatively new product, that's come to America anyway, that, it's nice that, it's becoming more widespread and, the knowledge of the uses of it.
Like I said, I've had great success with it using it since 2016. And I find that my patients are, when I explain them the benefit of it, they're very appreciative. I think
Mhm.
patients actually, you know, would much prefer conservative therapy that also doesn't result in post-op discomfort.